So welcome back. And after that really engaging session this morning, I'm sure we are all infused and enthusiastic to keep going on. My name is Ramya Ramanujachar, and I'm a pediatric oncologist in Southampton. And it gives me really great pleasure to be moderating this session and listening to our experts today, 4 of them, who will be chatting to us and giving us lots of information, understanding treatment-related late effects. We have Dr. Assunta Albanese, pediatric oncologist from Marsden, Dr. Urshla Devalia, pediatric dental consultant from the Royal National ENT and Eastman Dental Hospital, Dr. Naureen prosthodontist at the University College Hospital, London, Dr. Paula Adkin, pediatric oncologist from the Pediatric Teenage and Young Adult Long-Term Follow-Up Clinic at the Marsden. So without great time, we will get going, and over to Dr. Assunta Albanese, who's going to be presenting on ovarian insufficiency in girls and pubertal induction. Thank you.
Thank you very much for inviting me to share this topic, which is very close to my heart. I'm an endocrinologist, and I've been working at the Royal Marsden since 1999. So long time, a lot of experience which have been accumulating over the years, and I'm going to share part of that with you. So just to remind and to give an idea of what I'm going to talk, I will go through the main key milestones of puberty. Then we'll discuss when puberty needs to be helped, it needs to be induced. What are we aiming to obtain and what are we looking to forward? And also, how can we do it? Just some example, and eventually we'll draw some conclusion together. So you will remember from your youth or from having older children that in puberty can start at a very different time. There's an individual time frame. So from 9 to 13, usually we're expecting girls to have entered into puberty, and some of them have already completed puberty by the age of 13. And it's mainly due to the production of estrogen, which is the main female hormone, which is released from the ovary. And there is a main signal from the brain, which is telling the ovary to work, and puberty, usually as I tend to say, like a clock, it gets started. So in puberty, what are we expecting? First sign is the breast bath. Then we are having some growth in the uterus, and eventually there will be start of menses at the end of puberty. There will be a pubertal growth spurt, which is thank you to growth hormone and estrogen. And then there will be some changes which we are all familiar with, like for instance, wider hips in girls, accumulation of bone strength, and there will be other changes which are not so estrogen related, like changes in hair, in skin, having hair, and so on. And all the psychological, mental change which happen with puberty. So all the cognitive, motor skills, and connection that actually happen at the time of puberty. And increase in sexual curiosity and awareness that it makes as a parent us very anxious. Now, when do we need to help? When a girl needs some help? Really depends on the treatment that the girl went through and the intensity of the treatment. So the ovary is full with primordial follicles since we are born. You can see in this slide that at birth, a girl will have something like 1 million primordial follicles, and as time goes by, this number of follicles tends to decline, and then eventually when it goes below a certain number, around 700, 800, this is when a woman at the age in her 50 will go through menopause. It's not working anymore. So what's happening? If there is an insult, let's say for instance at this point, it was working before. So if there is an insult, for instance, when the girl is 10 years old, and this insult is leading to a loss of follicles, a depletion by more than 50%, you can see that what is left will be much less, and therefore there is less resilience, less number of follicles to take her to the usual age of menopause, and things will start happening much earlier. So it's the high usually high dose or alkylating agents, which are responsible for this, and radiotherapy. And very often it's the combination. And every girl is different because at birth, there are some girls who are born with much more follicles than some others. So there are genetic factors as well. And therefore it can happen that the same hit may have an earlier or later presentation according to the individual girl. The radiotherapy is also, unfortunately, if the uterus is within the radiotherapy fields, is also affected by the radiotherapy. And uterus is like a muscle. So after radiotherapy, it tends to be stiff. So what it can happen that it's not going to grow in the same way. It will lose some elasticity. The blood supply will be affected. And that's very important for later on in adult life, for outcome of pregnancy, and also for periods, if periods are going to be, is responding to the stimulation of hormones as expected. So when do we start? There is not a specific time for everybody, and we know that if a girl is at risk of ovarian insufficiency, it already tends to be referred to me in advance, when it's still young, usually 9, 10 years old, if it's needed. And what we do? We start keeping an eye. So if practically the girl already shows some signs of puberty, breast budding, fine. But we know if she's struggling at getting this breast budding or not by measuring FSH. And FSH is the hormone that, as I say, is the main conductor, which is orchestrating the puberty. So if everything goes smoothly as it should, because as I say, every girl is different, then you can see that clinically she's progressing to puberty. So from tiny less small breast buds, there will be progression and so on. And the follicles hormones will be completely, will be completely normal. So FSH will be level. But if FSH is high, usually it means that actually the number of follicles is low. And therefore we know that help is needed to start puberty if there are no signs of puberty at all and it's the right age, or to carry on progressing to puberty if there was a spontaneous onset but things they get stuck. So why it's important to do so? Because we want to have a normal life, we want to have normal girls. So we want to make sure that actually if we don't do anything, there is a lack of breast development. The uterus will not develop, it will stay as a tiny prepubertal small uterus. The growth will be affected because the growth spurt is going to be missed. We need estrogen to have a pubertal growth spurt. There will be a lack of all the development, neurocognitive developments, and that actually happening to puberty. And again, if you do nothing and the girl becomes a young adult, we know that without estrogen in adulthood, there is an increased risk of cardiovascular disease and osteoporosis, brittle bones. So what are we aiming to achieve? Exactly what we said at the beginning, to achieve all the key stage of development. So there should be a normal growth spurt. Height is very important as well, especially if there's been radiotherapy to the back, which might, in a certain way, affecting the total growth. Breast development is part of normal growth. Body shape as well. Having periods, if it's possible to get periods, and having a uterus that is mature enough that one day is able to have a good outcome, a better outcome when there is the introduction of assisted reproductive technology. We want a normal bone strength, and we want a normal psychological well-being. There is no way that it can fit everybody. So we are all different, and it's not a surprise that you don't do the same things in every single girl, because every girl is different, but the principles are very similar. So the starting time, the estrogen dose, the way the estrogen can be delivered to the girl, it's individualized. And usually it's agreed with parents and with the girl as well. It's very important to ask the girl, and very often I found some parents are not so ready to let it go, to have the girl say, but sometimes, or vice versa, sometimes the girl is very happy to talk to mom and mom talking to me, rather than for the girl talking to me. But it's very important to listen to what the girl says, because at the end of the day, what we are aiming for is to have a girl that is growing up, self-confident, and it doesn't feel different from other girls of their age and go through the same stages of puberty as everybody does. Maybe a little bit delayed, but still going through puberty. So which are the main principles? We are starting at an age where it's expected to be in puberty, and very often we take into account also, for instance, the maturity of the girl, and parents will be guiding me, or for instance, their family history. So there are some family where every girl in that family was very late in development. So for them it's normal if a girl is already 12 and a half, 13, is just about to start, because that's the family trend. And we are aiming therefore to start when it's the right age, and to complete over more or less, usually 3 years, more or less it takes to complete pubertal development, which is what it takes in nature. It's a slow process, so we need to go slowly. So there are progressive, we are starting with low doses and we're increasing progressively, usually every 6 months. We are starting with, as I say, with a very low dose, and the increments are very small, because we want to make sure that there are no big jumps, not only from emotional point of view, but also for the physical changes, so the breast seems to develop in a normal way. Everybody knows that when we talk about puberty hormone, there's estrogen, progesterone. Actually, estrogen is the main hormone that we need, because progesterone is only introduced to keep the womb, the uterus healthy, and is done at the end of pubertal development just to keep the uterus, the endometrial lining, shredding or healthy. Therefore, there is no risk of building up inside the womb. When I started 26 years ago, we didn't have a 17-beta estradiol. We used to use 18-yl estradiol, which actually is the same estrogen, synthetic estrogen, which is the one that we found in contraceptive pill. While 17-beta estradiol is the same estrogen our body is making, and that's very, very important. So now almost everybody all around the world tend to use 17-beta estradiol, because, as I say, it's more physiological. It's available in tablets, in patches, and in gel. Tablets are very difficult because we don't have any product that is just for adolescents. We don't have anything that is just made by the drug company to induce puberty. So we really need to use our imagination, and we need to use product that actually can be easily cut. Very small dose can be easily given. So if a tablet is let's say 1 milligram, I cannot ask any parents to give 1/6 of a tablet, which is impossible. While with patches, especially when they develop a patch which it can be cut, and it keeps all the, is good within, despite being cut, this is when actually we start using 17-beta estradiol. So what we tend to prefer is the transdermal, so using a patch or using a gel. Because if we are using a patch and we apply on the skin, the estrogen is absorbed directly from the skin to the bloodstream. And this is similar to what happens in the body. From the ovary, it goes to the bloodstream. Well, if you're giving a tablet, the tablet needs to be digested and needs to go through the liver. So it tends to be changed. So the first choice, if it's possible, is always transdermal. And with a gel, it's very difficult to give a small doses. Again, I can't say 1/5 of a blob, because it comes in blobs. While with a patch, I will show you that it's much easier to cut. So the patches, as we say, the flavor of the month, and there's been the flavor of the month for many, many years now, because we also know that not only is bypassing the liver, but we know from study in adulthood, because the 17-beta estradiol is what is found in HRT, it tends to be safer on blood pressure, on cardiovascular profile, and it's got a lower thromboembolic risk compared to the 18-yl estradiol, which is found in a pill. However, we are not identical. Patches might not be tolerated. Some girls might refuse having a patch, or some girls, but that patch is not going to stick. So, or there can be a local allergy. So we need to have more other way to do things, and that's what actually we do. And also applying the same patch, same dose, the absorption can be different. There are what we call inter-individual changes, responses, that we need to take into account. Again, as you grow up, as somebody goes to uni, as the young lady is sharing a flat with other girls, she may not be happy to have a box of HRT, but he will be more happy and more confident in using a box of contraceptive pill. And these are options that as you grow, they are possible as well. So as I said, it needs to be individualized. I told you the patches because really that's what we are mainly using, especially at the beginning if it's tolerated. They are self-adhesive, they are very small. I tend to say keep them in the fridge once they are cut, so we are not losing any of that property. And if it doesn't stick properly, put a micropore on top of it. Usually goes below the waist, and usually let's say under the belly button. It's like a smiling face where your pants are. So it's hidden, it's there. Every time you go to toilet, you can see that it's still there. You have not lost it. Every patch, it will release a hormone up to 4 days. So if you're keeping the same patch longer than 4 days, it's just a sticky patch. There is no medication. So this is why we tend to say, remember, it needs to be changed every 3 to 4 days. And usually we say choose 2 days in the week, Monday and Thursday, where actually the gap will be 3 or 4 days. And they will be and you always stick to the same rule. The size should be rotated because otherwise the absorption is not so good. And we always say try to avoid to apply patches, for instance, on your legs, because where there is a little bit of fat, there is an increased risk of cellulitis, and we don't want cellulitis for this reason. So just to give you an idea, this is one way to get started with patches. At the beginning, for the first 6 months of treatment, if a girl is 12 years old, so she's still young, and there are no signs of breast, what we do, we start from the very, very beginning. So in nature, it's mainly this FSH, this stimulation, is mainly at night time. Daytime, is everything quiet. And what we do in this situation, we apply a very small amount, 1/8 or 1/6 of a patch, according to the size of the girl, bedtime, and is removed in the morning. So there is only an overnight stimulation. On the other hand, if at the same age, a girl is already starting a very early breast baths, but we know that she will not be able to progress into puberty on her own, because what I mentioned, the main regulator FSH is high already. We know that we don't need to start from a very tiny, tiny little dose just overnight, but we can go already to the twice weekly regime, and we are using, for instance, a quarter of a patch, which is changed twice a week. If a girl, on the other hand, is presenting to me and she's 13, because she completed her treatment then, or for whatever reason, she's older, so if there is no breast bath, we are not starting from the very, very beginning, because we don't want it to wait. You know, puberty has to happen within a certain time frame. We need to go a little bit faster. And the older is the child, the more important is to be sure that actually we are not prolonging this process for too long. And we already started with a quarter of a patch. And if there is early buds already, for instance, you can use half of a patch, change twice a week. Then what happened? We say at one point, when the uterus is developed, when the breast development is developed, and this means that we are at the end of our pubertal induction, this is when actually we're introducing progesterone. And the progesterone, we can start playing with it. So, for instance, some women, and usually many, many girls, they really like having a cycle. So if it's possible to have a bleeding once a month. And this is when actually we are using some tablets. At this point, the doses are appropriate for teenagers, or patches which are made in a way where actually you can have a cycle without bleeding. All those patches, they can contain the same dose of estrogen and progesterone all the way through, and therefore there are no menses, but it takes few months before you don't get any menses, so it needs some time. Or, for instance, some girls say, I want to take the estrogen by mouth or transdermally, and then, for instance, only for 2 weeks every month, I want to add progesterone. So they want to feel more in control. And in this case, for instance, we say at the beginning of the month, for the first 2 weeks, take estrogen, whatever the estrogen you are taking, through the gel, through the patches, or through the tablets, and then you can go on top with some progesterone. And this gives the flexibility, for instance, that you can choose which progesterone to use to suit the specific girl. What I remind every girl, HRT, what we are using is not a contraception. And I always say life is unpredictable. So if a girl eventually we can't call ovarian failure, we call ovarian insufficiency, because there have been cases where nobody is expecting, there is an ovulation, And therefore, if the girl is sexually active, the woman is sexually active, there is, in theory, and there have been cases where a pregnancy happened. And we want to have wanted pregnancy. So when they become sexually active, what I say, be careful, because this is not a contraceptive. So even though your risk of pregnancy is extremely low, so to consider using a contraception. And for instance, personally, I always say, consider a barrier, because you need to protect yourself for sexually transmitted infection, which is unfortunately one of the current problems among our youth. And what is important about this HRT, it doesn't stop your body from doing what it's able to do. So you can add it up to what your body is doing. So in conclusion, the time of induction of puberty and the way that estrogen is given and also the dose, it should be individualized, because every girl is an individual. After induction, there will be some preference. Some girls will love to have, for instance, cycling bleeding. Some girls will prefer not to. Or, for instance, they will be more in control and deciding when to take progesterone or whatsoever. And each, when you're starting in a certain way, even though it works, now and then it's important to stop and thinking. Stopping means discussing and say, are you happy? Is it really suiting you? Is something that is, is not working properly with you? Should we try something different? So it's not that we are starting one regimen when they are 12, and that's what actually they are going to have for the rest of their life. So, and also there is not new technology, there are new way of doing things, so it's important now and then to reassess. The duration usually is for many years, so it's important that we do it right. But what is the main problem is that we don't have so many trials, randomized trials, which are telling us that, for instance, doing in this way is better than the other way, so we are learning by experience. And we have been accumulating quite a lot of experience based on knowing the physiology very well. And the long-term outcome data, actually, we are starting collecting them. Thank you.
Thank you. Thank you very much, Dr. Albanese, for this really informative session. Now, over to Dr. Devalia, who's going to be talking about the impact of childhood chemotherapy and radiotherapy on oral health. Thank you.
Thank you. Just check I have the right pointer. There we go. Thank you very much, everybody, for inviting me here today to talk to you. You'll see this poster dotted around without the hall today, which is asking a little bit of a survey about oral health and what kind of experiences you've had during your child's cancer journey. And Mini Mouth Care Matters is an initiative which I started about 6-7 years ago now, which is recognising the importance of oral health as part of medical treatment. We are thought of as so much in silos. Actually, we need to be better at coordination. And so please, if I can ask you to, and part of me being able to do this today was also getting some donations of toothbrushes and toothpaste, which you'll see outside from Henry Schein, so please do help yourself. Now, obviously I'm going to talk to you about the impact of childhood chemotherapy and radiotherapy. And while my first slide talks about my multiple qualifications, things that I do locally, regionally, nationally, actually I almost didn't do this talk today. And it was a big ask for me, and the minute I stepped through the doors, actually I burst out crying. In fact, I should probably have some tissues now. So being on the other side of somebody who has been really passionate about oral health, medical complexities, and how it's always forgotten. Last year, in July, my daughter was diagnosed with rheumatoid arthritis, which actually was a misdiagnosis. And in fact, this photo was taken about 2 hours after I told her that she actually has leukemia. So, sorry, apologies. So it was our last moments of normality before what then ensued of 6 or 7 weeks of, months of really intense treatment. And I knew I should have had some tissues with me, sorry. As soon as I walked through the door today, the poor ladies at the front desk had to deal with my tears. And I haven't actually cried about things because I'm not somebody who thinks in the future. And this is about survivorship and what happens later on. And I don't think like that about my own child. For everybody else I do, but not for her. I'm dealing with things at the moment. But she's the most amazing, resilient little girl. She's 8 years old and she's doing amazingly well. So I thought it important to share my journey with you because actually, this is my not lived experience. I'm living through this right now. We are only 7 months into a long journey, and everything I fought for before actually becomes even more important. So the only thing I can do in these scenarios is talk about what I'm an expert in, and I'm an expert in oral health. So I want to share a bit of knowledge with you on why oral health is important, what are the long-term effects on oral and dental health for chemotherapy and radiotherapy, and what can be done to support good oral health. I will stop the wavering in a second, I'll get into the groove of things. So a little bit of generic information, first of all, about why good oral health is important. And this is what I'm talking about. We think of it as so separate to the rest of our body, and it's not. The mouth is the body, is the kind of window to the rest of our soul, the rest of our systems. It really is everything in terms of holistic care we need to be thinking about, in terms of your overall health and well-being. And that's not just me saying that. We know there are known associations between oral health, diabetes, cardiovascular disease. These are known things that we can do things about. And there has been plenty of research for children and young people with poor oral health that show actually a stunted growth, low birth weight, less able to concentrate at school. So there are really important things that we can do collectively to manage that. And oral health is really known as a key determinant of quality of life. And so I'm really glad to be here to be able to talk to you about this. Now, again, a very kind of generic conversation about oral health inequities that affect children and young people within the UK. And you will have seen on the news last week supervised toothbrushing pledge by the Labour government, which is brilliant. And it's a targeted approach for the 20% most deprived populations, but actually there are stark oral health inequities in the UK. So those from lower socioeconomic statuses are more likely to have dental disease and decay. There's a huge geographical divide, so those who live in the north, those who live in rural and coastal areas are more likely to be impacted by poor oral health. Those from Black, Asian and minority ethnic groups are also more likely to suffer from poor oral health. And children and young people with disabilities present 50% more with untreated dental decay than those mainstream peers who have 23% untreated dental decay. And there's also a lack of public awareness and health literacy between our families. So having a platform to explain the relevance of this to people within their own societies is important. And in terms of disability, my child is now somebody with a blue badge, it's somebody with a disability. These are things affecting all of us. And there is a risk of our children and young people being in this category. So let's go back and talk about why we're here today. Pediatric oncology patients are 3 times more likely to present with oral health complications than adult oncology patients. And apart from the obvious side effects that we know that happens to our blood during this treatment, actually the most commonly reported side effects for all of these treatments are related to oral health conditions. So why is it relevant to neuroblastoma? And this slide here, this picture actually makes me feel a little bit funny. It's like barnacles, it just goes through me, I don't know why. But it's important to put it up here for perspective. And what it essentially is showing is that the development of teeth actually starts at 4 months in utero. So before a child is born, their teeth are starting to develop. And as we know, the average age of diagnosis for neuroblastoma is between 1 and 2, and 9 out of 10 children are diagnosed by the age of 5. They are critical time points within the development of your dentition, baby teeth and adult teeth that can be affected by any sort of systemic disturbance. This isn't just isolated to oncology patients. In fact, if we have a child or a mum who has a really difficult birth and it ends up being traumatic and ends up being an emergency C-section, that kind of insult at that moment in time has an effect on your teeth, and we see that every single day. But for our particular cohort of patients, it's a lot more likely to happen because of the age of diagnosis. So that's really relevant for why I'm here to talk to you today about things that we can potentially do. Now, when we were given my daughter's diagnosis, we were bombarded with an hour of complications of things that can go wrong. And I don't want anybody to feel like this is the sort of thing to worry about, because actually everybody's journey, as the last lady just said, is individualized. So it's just to make you aware of what things could happen and to give you the tools to manage those if it is something that you recognize for your child later on. So the more common dental anomalies we see for children who have had any sort of cancer treatment are something called microdontia, or small teeth. We can see some root stunting, so shortened roots. There may be missing teeth, and really commonly something we see called enamel hyperplasia, or weak teeth. But this depends. All of these may happen, none of them may happen. It depends on the type of treatment the child has had, how intense the treatment has been, the age at the time of diagnosis, and the location of the tumor. And I also want to point out in terms of statistics, don't worry about it. Like we said, everybody's individualized. We know there's going to be a high likelihood of having a sort of dental anomaly. but we can't be that specific in terms of these. As the lady said before, there are randomized control trials. We know in terms of evidence what happens, but this particular slide, some evidence goes between 2 and 80%. So there's different evidence everywhere. It's just to make you aware. So microdontia presents as these kind of abnormally small teeth, and it usually happens in children where they're under the age of 3. I don't know if this pointer is working. It is? Maybe I just don't know which button to press. There we go. Okay, so it's really obvious. I don't need a pointer here. Really small ones. My husband's a dentist. He asked me last night when I flicked through these slides, why have you got black and white pictures? I really don't know. I have black and white pictures. I should have color ones, but it's just to highlight, these are some of the things that we can see in terms of microdontia. Now, shortened roots or root stunting is quite important, and actually as a dentist, it's kind of something quite stark that we often see. And we can see the really, really short roots, and we call it a short crown to root ratio. So the crown is the bit of the tooth you see in the mouth, the root is the bit that sits in the bone. And what happens if you haven't got much kind of stuck in the mud and you've got something really tall on top of it? There can be instability, and teeth may become a bit mobile and a bit wobbly. And while the X-ray might not look the best in terms of these very, very short roots everywhere, in fact, in the mouth, it doesn't look too bad. So again, things that you might not be able to see when you're visually looking at somebody can be picked up on dental X-rays. So it's important to have that coordination and to see the right person to help you pick up on these anomalies. Now, hypodontia, or missing teeth, and this particular picture I can show you here, it's showing where we're missing teeth at the back. So the yellow stars are the back teeth which are missing. The red is showing you where we have the root stunting, or those short roots. And the blue arrows are pointing to areas of dental decay. Now, the reason why they're pointed out here is because it's really unusual to get decay on the back of a molar tooth. Usually, decay presents itself on the top, on the biting surfaces of your teeth. So if you're missing teeth at the back, if we're not cleaning appropriately, we're going to be getting areas of decay which wouldn't normally be picked up by just looking in the mouth. So really important that missing teeth can have implications in the terms of things that can be missed when you're looking after your teeth later on. Now, enamel hypoplasia essentially means a defect in the quality of the enamel. And this can range from anything to mild with very, very little bit of chalky appearance on a tooth, to a little bit more broken down, or to really crumbly teeth. Now, to a lay dentist or a high street dentist who might not be used to seeing these sorts of things, these could potentially be diagnosed as decay, or you're not looking after your teeth, and actually it's not. They're really weak enamel, weak quality of the tooth. So as soon as it erupts, it starts to crumble. And there are things that we can do about this. It's just to be aware that these are the complications we might see, to be able to pick them up early. Now, the relevance of the qualitative defect on the front teeth is front teeth don't often get dental decay because they're smooth surfaces, whereas your back teeth have got lots of grooves in them. But the problem with hypoplasia on front teeth is that it actually has loads and loads of grooves everywhere. So the bugs and bacteria are much more likely to get stuck into these teeth and are more likely to cause decay. So we have to be really vigilant with any sort of hypoplasia on front teeth, because there are long-term consequences for obviously having decay on front teeth in terms of aesthetics, management, and confidence later on in life. Now, there are some non-dental side effects to be aware of as well. The development of the jaws, maxilla and the mandible, there may be a bit of asymmetry. There could be a decreased growth. Again, all of these depend on the type of treatment, where the treatment has been done, and more so in the craniofacial region if we're looking at sort of radiotherapy that's taken place in the head and neck. This trismus or spasms, essentially making it really difficult to open your mouth, that can make it difficult to get access for dental treatment, or even something as simple having access for a toothbrush to brush your teeth. So these are things to be aware of in terms of managing what we can do at home. So mucositis, and this is something that my daughter has suffered quite a lot of throughout her treatment, is essentially the inflammation of the soft tissues of the mouth. And then as a side effect of treatment, there might be some vomiting, and this can cause an acidic environment. So if you do have hypoplasia, having this kind of acidic environment doesn't make it very conducive to having a clean mouth. And there are possible consequences with long-term gum disease as well. Now, one of the important things to note is if there is any radiotherapy taking place in the head and neck, it can often affect the salivary glands. And this causes something called xerostomia, or just dry mouth.
And xerostomia is quite important because not only does it then potentially result in a loss of taste with foods, but it can make it really difficult to chew and swallow. It can make it difficult to do a presentation like now, my mouth's a bit dry. So, these are really important things. But also the key factor of saliva is it's a regulatory mechanism for stopping dental decay. It provides those buffering mechanisms. So without the natural production of saliva, all of those bacteria which are usually cleaned out, things like you can get with a fungal infection, actually make it much more likely to be prone to infections in the mouth. And there are things that we can do in terms of saliva substitutes, sugar-free gums, things that we can do to help promote the production of saliva on a local level, or there can be prescribed drugs as well, which can help to produce saliva to reintroduce that clearing mechanism. So essentially, we have a perfect storm of almost consequences that will happen or could happen as a side effect of treatment. And again, not everybody, but in some cases it will happen, where we get a reduced saliva flow, so that normal buffering mechanism is gone. There's the potential for these enamel defects causing the weak quality of the teeth, the acidic environment if there's been potential vomiting, which can make it difficult to brush teeth, or people risk averse to brushing their teeth later on, they don't like the feel of it. And all of that can lead to dental decay. Now that's the most important thing I want you to take away from my talk today. That's the thing that we can potentially do something about. We can manage the dental decay. The other things, we don't have a choice. Medical treatment will always supersede the need for dental consequences later on, and there are things that we can do, and my colleague Naureen will talk about management of some of these things in the next presentation. But what can we do at home? So early intervention, I heard the chap earlier talking about survivorship plans, and actually dental survivorship is something that doesn't really exist widely in the UK. I've started to have conversations about it, and I will follow through on them after the meeting today as well. So we want to make sure we're asking for that kind of package of care to make sure that there is a long-term input from a pediatric specialist or a dental specialist where you need before treatment ends, to make sure you have those measures in place. Some of these consequences or side effects will happen way down the line, and we don't want to be in a position where we've been discharged and all of a sudden you're in a system where I can't access a dentist and there are real complications that need to be managed. So see if we can build dental into your long-term plan. Keep an eye out for things such as white patches, loose teeth, which means you may not see it in the mouth, but there could be some shortened roots, and an eye on potentially jaw pain and delayed tooth eruption. So these are things that we can monitor at home. And accessing care, if you can't access a dentist, they have to direct you to NHS 111, unfortunately. But my email address is here. If you do need any specialist care, please ask. I'm also, in one of my roles, a managed clinical network chair for paediatric dentistry for the East of England, and I have a lot of contacts. So if anybody needs a specialist dentist and you're struggling, please just send me an email and I can help you find your local dentist in your area. So prevention is key. That's the thing we can do. And our basic prevention messages are we want to be brushing twice a day. And what we know, the best thing that works is brushing last thing at night and any other time of day. So the nighttime brushing is the most important, and that's because of the further reduced salivary flow when we go to sleep at night. We need to be using a fluoridated toothpaste, and don't worry about these children's toothpaste. Everybody with a diagnosis should be on an adult content toothpaste, so we want a grown-up toothpaste. Now, supervised toothbrushing should happen until the age of 6, or until the child can write in joined-up handwriting or tie their shoelaces. It's all about the dexterity. If you want to support beyond that, that's fine. Now, one of the key messages we always promote is spit, don't rinse. So toothpaste is a bit like hand cream. It works topically by sitting on your teeth, the same thing as hand cream. Now, you wouldn't put hand cream on and then go and wash your hands, but yet we brush teeth and then we rinse out with water, so we're washing the fluoride away. So don't do that. Brush your teeth, spit, leave a layer of toothpaste in your teeth. It's the most important way to prevent decay. Actually reduces decay by more than 35%. In terms of drinks, every drink will damage your teeth in some way apart from water, and plain milk. Everything else has potential damaging effects. Now, I'm not saying you can't drink other things, but drink them with a straw and keep them to a meal time. Otherwise, plain water and plain milk in between meals. And again, sweet treats, we're going to have them, but try and keep them to meal times to limit that kind of acid attack. I've seen somewhere in some articles about the importance of seeing a dentist every 6 to 12 months, but actually everything is based on your risk, and these children will be diagnosed as having a higher risk group. So every 3 months, every 4 months, it should be tailored to the individual, and that will be to have this fluoride varnish application, a really strong boost of fluoride as a preventive measure to prevent decay forming in the future. And at some points that your dentist may want to take an x-ray, this big radiograph, to see are there any potential anomalies that we can catch early and put a referral in place if need be. So in conclusion, we know that our children are potentially going to have a higher likelihood of long-term oral health complications. Not to be worried about the things I've presented, they are manageable. Those are the things that are out of our hands, so control what we can do, which is prevention. The better oral health we have, the more options going forward. If you go and present to a dentist with a mouthful of decay, your options are very, very limited. So we want to be brushing regularly and do the things that we can do to make sure there are more options for us in the future. Prevention really is the key. And as the conference is about hope, you know, hope from my side to share with you today. This is my daughter finally going back to school last week after 7 months of being at home with me. I need a cat now because I'm very lonely at home. But, you know, she has done amazingly well, and I share my hope with all of you here today as well. And thank you so much. Please spend some time to fill the survey in. Thank you.
Really insightful, but also the personal touch to it. I now invite Dr. Rizvi, who will be presenting on restorative options for dental challenges after childhood treatment, cancer treatment. Thank you.
Good morning, everyone. Thank you for having me. So I'd like to follow on from Dr. Devalia's talk on restorative options after childhood dental treatment. So a little bit about me. I'm a specialist in prosthodontics, and my specialty involves restoration of teeth following conditions such as shortened teeth, small teeth, and discolorations. And really, I'm just involved in the rehabilitation of such conditions. I'm a clinical lecturer at the Eastman Dental Hospital, and I also work in practice in London. So the aims of restorative management really are to provide dental restorations that are tailored to the individual needs, restoring oral health and function and aesthetics, and really giving the power to individuals to move forward with confidence, transitioning from childhood into adulthood as smoothly as possible. So this is where we work at UCLH, and the dental team involved in treating these dental conditions are, the pediatric dental team, which we've heard all about, the nursing team, the orthodontic team, which are involved in the movement of teeth and the preservation of spaces, and then later on, prosthodontic and restorative teams that are involved in the restoration of the teeth, and we're actually involved quite early on throughout the planning stages as well. So as we've gone through this morning, the common dental challenges that we see are microdontia, which is small teeth, missing teeth, which is known as hypodontia, weak or fragile teeth, and this is known as enamel hyperplasia. So these teeth tend to be quite prone to wearing away, prone to having decay, and it's all about, as Dr. Devalia touched on, the prevention is key in these cases. So fluoride treatment, good oral hygiene, regular follow-ups are really important. And then to treat the tooth wear, this is something that is one of my special interests. Not only are these teeth susceptible to wear, but they're susceptible to the acid erosion, vomiting, and we also see shortened dental roots, so these teeth can tend to be mobile, and as a result of radiation and chemotherapy, the jaw growth is sometimes altered, which can result in some asymmetries. But the real key message that I'd like you to take home today is that all of these are treatable and manageable in a predictable way. And there's lots of good conservative solutions available to treat these. So we'll go through some of these today. So missing and small teeth are usually treated with restorations, or they're replaced with prostheses that can be fixed or removable. And there are lots of conservative, gentle, effective treatments that can be pain-free. The treatment options that we explore are all tailored to the children's individual age, their needs, and the stage of growth that they're at. So in missing teeth in children, we've got this on the left-hand side. This is what we call a space maintainer. So if teeth are lost early on or they're missing, we can actually apply these metal bands that hold the space open, and this can keep space for example, if you're replacing this tooth, an implant or a bridge, or if you're simply waiting for the adult tooth to come through, this can be a very good solution to holding teeth where they are and buying some time in children. Orthodontic treatments, we've got an example of fixed braces on the left-hand side. These can be used to optimize the spaces, move teeth into the right position, and adapt the growth as we go into adolescence. And then partial dentures is where we've got missing teeth, aesthetics are affected, and we really need a solution to replace these teeth and you know, help with eating and speaking. So where we've got small and weakened teeth, there's lots of different options out there, and the options that we would explore really depend on the severity of the case. So if you've got mild cases where the teeth are slightly discoloured or they may have some anomalies in the shape, we can apply some additive techniques. So without cutting any of the tooth away, you could apply some composite bonding, and then in kind of more severe cases where you've got more discoloration, or we might need to subtract a little bit of the tooth and then bond some veneers or crowns. Where we've got moderate cases, where we've got missing teeth or teeth need to be extracted, we've got fixed or removable options such as bridges, and in more severe cases, we've got dentures that can fit over the teeth, replace missing teeth, and implants. And really with implants, it's key that these are placed when the growth is complete. So this is an example of a composite restoration. So this is a tooth that has hypoplasia. It got quite decayed, and you can see that it's been restored very conservatively, and it's been repaired without really cutting any of the tooth apart from the decayed portion. And it's repairable if it chips. It's got good aesthetics, but it does require maintenance in the long term. And then you've got ceramic or metal onlay. So an onlay is, if the tooth is quite heavily broken down, you can actually ask a laboratory to fabricate a restoration for, and you can just kind of see that join line where the tooth meets the ceramic, but I think the aesthetics are pretty good. So there are lots of good options available depending on the amount of tooth structure that's lost. So this is an example of a case, patient with acid erosion. So you can see on the left-hand side, these are the models of the teeth, and they've kind of been dished out just from being bathed in the acid, and it's quite severe. And on the left-hand side, it's the same patient, and the teeth have been built up with composites, and none of the patient's own tooth structure has been removed. And this patient was only 20 years old. So rather than kind of going through any sort of destructive treatment like crowns or things where we cut the tooth away, this is the patient has maintained all of their own natural tooth. And again, it can last quite a long time, but it needs to be repaired over a period of time. And then this is an example of a resin-bonded bridge. So the patient is missing a tooth on the left-hand side. So this is what we call hypodontia. And the bridge is this picture on the left-hand side. So it's got a metal structure, and there's porcelain that goes over it. And you can very conservatively bond this, and you can see it's being bonded in the picture on the left-hand side. And again, no cutting away of the patient's own tooth. It's just being securely cemented on, and about 8 in 10 can last up to 10 years if they're well looked after, and it's just important to keep seeing a dentist for regular follow-ups and making sure that there's no decay happening underneath, because they can debond and they can chip. And then moving on to dental implants. So where we've got missing teeth, we can replace the teeth by inserting a screw into the jawbone, and this is the implant fixture, and on top of it we've got a crown that is cemented on top. But as this is fixed into the bone, it's best to wait until the patient is about 21 years old. So in females we say about 21, males it can be a little bit later, so 22, 23. And we plan for this early. So if the child is missing teeth early on, it's good to get the restorative team and the prosthodontic team to actually plan where we plan these implants to go, and then work together with orthodontics and pediatrics and make sure we're maintaining that space into adulthood. So it's got long-term success rates, so about 95% are still there after 10 years if they're well looked after. Obviously, it depends case to case. There's lots of different options, as you can see, depending on what the patient needs and the anomalies that we see. And this is an example of a patient that did have, using braces to hold the space open, had some temporary bridges, and then we can plan with CT scanning exactly where the implants will go, and that's her after she's stopped growing, and you can see quite a good aesthetic result there. So it's just all about that planning and making sure that we have something as the patient goes from childhood to adulthood. And these are dentures. So here we've got a child missing the front 4 teeth, obviously too young for implants and bridges and so on, but you can, again, get quite good aesthetics, and the patient's able to eat and drink and go to school without noticing that there is something missing there. And then just to kind of talk about some of the newer advancements in technology. So it can be quite tricky to tolerate, messy impressions that you have to wait for a while for them to set. So we've got new scanners and more in use in the hospital and in practice. It's like a little digital one that you can see in the top left-hand picture there, and it just goes all the way around, takes a series of pictures, and you end up with a 3D image of the teeth that you can send to the lab straight away. And because they are sent to the lab straight away, you can actually get these prostheses turned around at a quicker time. So if you do need to replace teeth at short notice and so on, you've always got these technology that we can use to make things a lot easier. So really, to summarise, the patient journey would involve regular appointments. So with dental treatment, there are quite a lot of visits to the hospital and the practice. We help to make that transition as smooth as possible, and helping children thrive emotionally and socially as they go through their treatment. So it starts from the acute phase, if there's painful teeth or decayed teeth, treating them, preventing the decay and preventing the disease in the teeth, the gum disease and so on, stabilising that, and then planning for the restorations and helping maintain them long term. So really, we work as a team with good communication to help restore confidence and function. There's lots of different options available out there that it's well worth having a discussion with dentists and start that process early on so that you know all of the options available. And really, with good planning, we can offer really good long-term solutions that are conservative and can last a very long time. Thank you.
So thank you very much, and that was really informative. And we move on to our last speaker, Dr. Adkin, who will be presenting on recommendations for long-term follow-up care. Thank you.
Thank you so much for the introduction. It's a real honour to come and speak to you all today. There's been so many fantastic speakers. My name's Paula Adkin. I'm a specialty doctor in paediatric and teenage and young adult long-term follow-up at the Royal Marsden in London. And I'm going to be talking to you on survivorship and giving you an overview of long-term follow-up. But really, my take-home message is going to be that when your child progresses into long-term follow-up, it may feel a bit daunting, but I promise you, you're going to be supported all the way. I'm just going to give you an overview of some pathways, but try not to overburden you with too many details. So in 2007, an expert panel met in Italy to produce a set of principles concerning the survivors of childhood and adolescent cancer. And the result was this Urshla statement, which reads, "The long-term goal of the cure and care of a child with cancer is that he or she becomes a resilient and autonomous adult with optimal health-related quality of life and accepted in society at the same level of his or her peers." In addition, a declaration was published by the Childhood Cancer International Survivors Network, where they asked for adequate long-term follow-up clinics with access to personalised care, more research for childhood cancer survivors, support in transitioning and sharing information when their children progress into adult clinics. And that's really been supported through the advent of treatment summaries and care plans, which has been touched on, and I'll give a little bit more detail further in the talk. The availability of adequate psychosocial support, equal opportunities in society, including education, employment, insurance, and awareness of the general public in order to dispel any misconceptions about childhood cancer. And this is happening. This is happening internationally. It's happening all around the country. So we now have long-term follow-up clinics of 21 in total all around the UK. And we're a network, and we communicate very closely. And that's just to make sure that we all remain updated and that we're supporting you and your children adequately as they progress through our clinics. So our setup at the Royal Marsden in London is that we have paediatric clinics when your child is under the age of 16, and we have oncologists who specialise in long-term follow-up care, paediatric endocrinologists and clinical nurse specialists. And we start talking to them about transition at age between 13 and 16, and then at 16 they pass into our teenage and young adult clinics, where we're lucky enough at the Marsden for that all to be on the same site, so it's very similar health professionals. We invite young people in this clinic, in the teenage and young adult clinic, to come in on their own, perhaps just for the first 5 minutes in the first year or two in this clinic, with mum or dad waiting outside. We're always there for support if needed. And I'm always very aware that you have all been on your journey with your child as well, and you want to know just as much detail, but while trying to hand over the reins to your child. So I'll always try and come and speak to you as well, perhaps on your own if you have kind of individual questions. So we start seeing children in our long-term follow-up clinic anywhere from about 2 to 5 years after the end of treatment, and that depends on the intensivity of the treatment they've received. And we generally see them on average annually, but we can start spacing out to 18 months or two yearly, depending on the number of touch bases that we need. And the focus is on survivorship. So we have a holistic approach. So we're not just managing symptoms. We support young people's mental health. We write support letters for education, talk about their transition into the workplace, and make sure that they know that we're here in the background. While we might not be calling them up to clinic more than once a year, once every 18 months, we're a form of support, so that you've always got our telephone number, and we're often receiving emails in between clinic, which is exactly what we want. And the treatment summary and care plan is such an important document, and I'll talk to you in detail about that. And as I touched on, while the focus is on the child, the support is for the whole family as well. And we often speak to parents on their own about how they're finding the change and the transition into a long-term follow-up clinic. We're also acutely aware it can be extremely anxiety-provoking coming back to your treating hospital, especially if you've not stepped through those doors for maybe up to a year or so. And where we try to is that we offer remote consultations, video consultations, if appropriate. And actually teenagers really do engage with that really nicely. It's a form of communication they're quite used to. We also know that this can be quite new information for your child. You may have received all of this during the consent process, but please be reassured we're acutely aware that there's quite sensitive topics that we might be discussing. This is always done in an age-appropriate manner and always done in partnership with yourselves. So as we touched on, like the big words such as cancer, the diagnosis, neuroblastoma, and chemotherapy, they are all words that we do want to introduce, but at a sensitive time, so that by the time they get to young adult age, they're able to describe with confidence what happened to them when they were younger. So we frame our discussions around what your child wants to talk about in that clinic, rather than it just being a list of possible side effects. We're here in the background monitoring for those side effects, but what we talk about in clinic is how they did with their footy team at the weekend, what video game they might like to be playing, so that when they do have that important question that they want to discuss with us, they know that we know them extremely well. And we talk about maintaining a healthy lifestyle, so healthy eating, recommending remaining active, and not starting smoking or vaping, we always touch on. So this is an example of our treatment summary at the Royal Marsden, and it beams up in a reasonably small text, but I just wanted to give an overview of the information that we want you and your child to receive. It's a detailed summary of the treatment, including chemotherapy, surgery, radiotherapy, and any important medical issues that they may have experienced. And what we pride ourselves is we collate all the information from the time that they were referred to our hospital, and we collate all this information into one document, because we're acutely aware that up to hundreds of letters may have been written during your time on treatment, so we try and have it all in one place. And while the first page is quite medical, the next few pages are written for you and your child. It's a care plan that they can refer back to. And it's so that you can digest and they can digest the recommendations for surveillance and monitoring. It's a breakdown of each system of the body for easy reference. So if there is something that they need to talk to their GP about, they know where to access that information and what's relevant. We always share it with their GP, but we always advise them to either have a hard copy or a picture on their phone, so they can really advocate for themselves and they become their own expert, but they're also sharing that knowledge with their future care team. And also, I've realised that actually it's incredibly useful to try and avoid repetition, because when you're moving into the adult world, you're going to be starting to see perhaps some specialists who haven't cared for you previously. And actually this treatment summary can just really outline exactly what was treated or what the treatment they received and what possible side effects. And at the bottom we always have sources of information for support for future reference, because otherwise it can be a lot of information in a clinic. And this nice summary chart at the back page basically just gives an overview of possible blood tests that we might like to be doing and surveillance scans. But really, it's a supportive clinic and an education role for the clinic, so that the children can come back to us and ask questions as they're growing up. So what's often asked is, what happens when I'm an adult? What's the pathways? And all around the country, there'll be different pathways of transitioning to adult care at slightly different ages. But the premise of it is that patients who've received more intensive chemotherapy, radiotherapy, will pass into adult long-term follow-up clinics and remain to be monitored. And that'll be hospital-based, and they'll have a multidisciplinary approach. Patients who've perhaps received lower intensity treatment can be discharged for supportive management by their GP with the treatment summary in hand, and we will only discharge them from our teenage and young adult clinic when we know that we have answered all their questions and they have fully digested all the information. As Tom touched on this morning, we work within our CCLG group and have produced these Living Beyond Cancer information pack. And it's available online as well, but we always give a copy when we first meet young people. And it can really help to answer many questions that you may have on your child's diagnosis and treatment and how it might affect their future health. And this is just a list of the fact sheets that are available. And what we pride ourselves in the treatment summary is that all this information is collated for you and is individualised into a treatment summary. But these fact sheets can just provide a little bit more detailed information if you so wish. And this is the QR code. Tom also touched on PanCare, which Emma and I are involved in, and it's really an organisation of late effect specialists and survivors where we meet up once a year across different European cities and make sure that we combine knowledge on research, supporting young people through education, and the optimal delivery of long-term follow-up healthcare. And I'm also involved in the IGHG, International Guideline Harmonisation Group. And really, I'm just putting these up here to say that you're not alone going through this next stage. There are specialists all over the world making sure that the knowledge is up to date to support you and making sure that guidelines are in place to share with health professionals looking after you. PanCare Surf Up is an example of one of the PanCare projects that is included over 80,000 survivors across Europe, so 11 different European countries, and it has just given us a wealth of data so that when we come to you and talk to you in your long-term follow-up clinic, we know exactly what each of those cumulative doses of chemotherapy might mean for your child, and so we can support you through that. In terms of the charities that we liaise with multiple charities internationally and nationally and locally, and obviously Solving Kids Cancer has just been a fantastic support. We try to make sure that we kind of individualise the recommendations for different charities, but it might mean that different parts of your journey you're supported by different charities, but they are out there. And when your child gets a little bit older, they may reach out for some peer support as well, and there are wonderful charities supporting them doing that. And I just wanted to finish on these powerful statements. We've heard some from our wonderful survivors this morning, and it really just echoes their comments. But the first is by Kelly, saying, since my treatment finished 10 years ago, I've been to university, graduated with a first, and trained as a teacher. All the goals I wanted to reach, I wouldn't take back having cancer. I've learned how strong I am and have become even more determined to succeed. And it's echoed by Chloe, who says, although I've faced many difficulties, I now realise it's enhanced my best traits. I'm a better version of myself. Finishing treatment is all about rediscovery. Your life might not be what you once envisioned, but you can find a new path. So I just want to thank you for your time, and this is just a reference for the CCLG support group. Thank you so much.
Thank you very much, Dr. Adkin. And may I invite all of the speakers to come up for panel discussion, please. And also we have Hannah Cohen, who is one of our parent and advocate. And we invite the floor to questions for the panel. Yeah. Do you have the mic? We have a lady here.
Hi, thank you. I've got two questions. One would be to Assunta, and then the other one would be to the dentist professionals. So my first one to Assunta, I have a background in pharmacy, so I'm really... when you were talking about the treatment options available for girls, my head instantly went to patient compliance and the lack of options that's available for the girls. So you can't use tablets, you can't use gel because you just can't make the appropriate doses. But cutting a patch also doesn't, you know, it works, but is it really the best thing in... where the children who've gone through cancer treatment are already kind of forgotten children, and in a society where women's health isn't always at the forefront, is there any pressure being put on pharmaceutical companies for them to make an appropriate product, especially when we've heard, you know, that in the UK there's 40,000 survivors of cancer. I don't know the figures of how much of those are sort of like male to female, but it's a huge amount. And then when you look at the numbers in Europe, so yeah, is there anything that's in the, you know, on the horizon to be able to make something appropriate for young girls?
Unfortunately, it doesn't pay back. The marketing is still too small. And also if we group all together the girls with different conditions where you need to intervene, it's too small market. And it's the same for testosterone for boys, so they're not interested. And I remember with my hat as a general endocrinologist for girls with Turner syndrome, which again, there is ovarian insufficiency, to try to get funding to have a trial in the UK, a randomized trial. It has been impossible. We went through for probably 15 years. We never ever managed, we made all the application to any charity, we never managed to get proper funding to do it, just because there is not really a big interest in terms of paying back.
Okay.
Very sorry.
I thought that would
pressure is there, but...
I thought that would be the answer.
No.
Am I right to ask my other question? So the one to the dental people would be, my son had his treatment in Sheffield, and I don't know if this is normal, obviously we only know what we know. We felt very lucky that we had a dentist that was accessible once a week for all the children, and she was very on it with different types of cancers, what their treatments, the side effects of their treatment would be for their oral health. And it meant that we kind of lapsed on him seeing our regular dentist because he was being seen once a week. Unfortunately, he passed away, and when we went to make an appointment ourselves, they kind of said, you've missed too many appointments. They did put us back on, but we found that he'd been taken off of their records because he'd missed so many appointments. And I put this out to other people, and we heard a lot of similar stories, and then people struggling to get back into routine NHS dental treatment. So I just wondered if there would be any way of being able to protect dental practice places for children who are seeing specialists during their treatment, for them to be able to kind of slip back into the NHS after their treatment. It frees up the appointments while they're seeing the specialists, but means that the long-term effects of their treatment can be caught when they can just slip back into their normal dental practice.
So since 2006, when the new dental contract came in, there's no such thing as dental registration. So everybody thinks I'm registered with a dentist. Actually, it doesn't exist anymore. So that's the big issue, is that as soon as you've lapsed an appointment, you're just a name that's disappeared into the ether, and that's for anybody and everyone. Even children who come to see us at the Eastman Dental Hospital, Naureen and I work in the same place. They're like, I've come to see you for my trauma of my front tooth, for example, but then nobody's been looking at the decay. And then after 2 years, they can't go back to their regular dentist because they've been discharged. Now, that's a huge gap that needs to be addressed. And as I mentioned, I've been a consultant for 11, 12 years now. First time I've heard of the terms dental survivorship was when I was preparing my talk. So as part of CCLG, I've been asked to be on the working group to talk about the long-term effects, to develop particular guidance and structure which will help, link in the groups better. The Royal College of Surgeons have got an oncology guidance, and they were presenting some patient leaflets they wanted to put at the back of the guidance. But going through the journey myself, my daughter's been under treatment for 7-8 months now. 3 times somebody's had a quick look in her mouth. Nobody has talked to us about oral health care. Nobody's included in her plans. And, I feel like, God, all my life work has failed. Nothing's actually happening. But these things are a slow burn. It takes a long time to happen. And I talked about the supervised toothbrushing. That's actually been going on in Scotland since 2006. It's been over almost 20 years. Only now England is catching up. So it's having conversations like this that will put it on the radar and, to reassure everybody. I'm coming in as president for BSPD next year, working with Royal College of Surgeons, RCPCH. We're going to be developing a toolkit. It's raising that awareness, and I promise I will advocate for everybody here as well as for my personal journey. And in terms of the kind of registration or keeping up with your dentist, I will have conversations with our Chief Dental Officer to make sure that's on the radar, because it's really not difficult. It's really not, just to make sure they're protected, and it might be, or it definitely will be, the coordination better between medical specialties and dentistry, and we just need to be working a lot closer to make sure that things are protected like that.
Can I just say also, hi, my name's Hannah. My son Jake was diagnosed in 2017, had a refractory treatment path, but he's just passed 5 years off treatment in October, so we're actually in that middle point right now. We had our last oncology clinic appointment in the autumn, and in autumn coming up, we'll have our first long-term follow-up care. He saw a dentist once in 2.5 years of treatment at Great Ormond Street, just before high-dose chemo, to check for cavities that might be implicated by infection, but otherwise we didn't see a dentist at all during his treatment path. And it was only because we'd heard vague rumblings that there might be some knock-on effects of teeth that we've been sort of, each time we go to the dentist, we remind them that he's been through lots of sort of cancer treatment. And he did have a couple of teeth that sort of erupted mid-jaw. He's 11 now. He had a couple of his adult teeth that came through sort of in his palate. And so we questioned it, and he got referred to an orthodontist. And it was like, actually, no, that's just his natural teeth development. And that's just what was going to happen to him anyway. But it felt like we've had to be there to advocate and remind. Yeah. to make sure that was checked, that we were passed to the right person, that we were passed back again. But dental thing, I feel like every part of his body was checked during treatment over and over again, and nobody looked at his teeth.
It's true. Yeah, and that's why when the little survey we've put out, I mean, essentially it's asking, during your cancer journey, did anybody ask you about oral health? And I was...
Mouth care during high-dose chemo, but apart from that, like nothing specific.
Exactly, and even I received those leaflets in my pack when we came in. It says, your nurse will look in your mouth. No, never happened. And, you'll see on that little symbol for Mini Mouth Care Matters, it's a little elephant that looks like a molar tooth. And essentially what's supposed to happen is that nurses, healthcare assistants, anybody in the ward, somebody to take responsibility for oral health. So as you go in the morning, say, have you been to the toilet? It's just like, have you brushed your teeth? Because we're all aware, and I will take my child, and we're kind of incentivized. But for those kids that actually don't have somebody, and it's not a priority for their family, if we haven't got our nursing medical teams, etc., advocating for them, something so basic, they're going to be on a GA list having teeth taken out. It's just, and then complications, delays for treatment. That's why I used to get called to the ward pre-BMT. You have to cancel your BMT actually because you've got dental infection we've only just picked up, and you've been having chemo for the last 4 or 5 months. So it's so disjointed. It needs to be seamlessly coordinated, and it's a long journey. I think it's just not a priority, but it's preventable, and that's the most annoying thing, is we know we can do something about it.
I feel now hearing everyone else's that we actually have probably got a standard that was really high.
Yeah, you did.
Yeah, my complaint now has become a really good thing that everyone else should be reaching for, I guess. Yeah. Thank you.
But that, I find also, getting to know lots of families in the SKC community over the years, during treatment and post-treatment, the discrepancy in how things are done between centres is vast. And so actually it's really important to be having these conversations to know, actually, well, they're getting that over there, so why aren't we getting that and pushing for that? So it's another really important part of these networks.
Yeah, on that note, actually, Dr. Devalia, I also had a comment and a question as well on that same. Yeah, it's really important having this session today, so you have highlighted the issues, so it becomes quite empowering for all of our parents now to be aware about these issues and actually go back to their dentist. But I would say as a professional, we hear this from the dentists themselves saying, A, awareness is not there, and B, some of them feel that they don't have that knowledge and expertise, and quite often the parents are turned away saying you need to go to a specialist. So how do you think, in your position and power, if you want to say, you're going to address all this? Because there is an NHS dentist close to their home who refuses to see them.
Yeah, so I think it's about also as medical teams writing to your local dentist if they have someone on their doorstep to say they need to be monitored every 3 months. 6 months is not a thing for children going through treatment. It has to be much more frequent than that. And they don't necessarily need to see a specialist early on, but they won't know to see anybody if the conversation doesn't happen. And my big push now is, a child with a congenital cardiac condition, before birth, they're going to have a heart problem. There's a risk of endocarditis going forward, which is, could potentially be life-threatening. So beforehand, at those medical clinics, why are we not having the conversation? Have you got a dentist? Let's get you to, it's prevention. We're catching things too late because it's just not on our radar. So it is about the coordination and making it important to our medical colleagues as well. And it's really not onerous to just ask, have you got a dentist? No, let's get you in. One of my colleagues who's doing some research up in Glasgow about exactly the coordination said to me, when would have been the right time in your daughter's journey for us as the dental team to come and see you? We're treated at Great Ormond Street as well. And I said, we don't need a specialist. We just want, the nurse could have said, have you got a dentist? When are you last seen? Done, tick box. These are the messages you need to do to look after your teeth. And then you're done. Don't waste that resource. You might not have needed to see somebody every couple of months, but I've had patients who have been seen for 80, 90 medical appointments, and then they come to me with a mouthful of infection. Why? Nobody's talked about it from minute one.
That's really powerful.
So it's the prevention part which is really important.
Hi, my main question is actually what Dr. Assunta kind of touched on, which is actually funding. So it's a question for all of you. You all individually talked about the different treatment option, whether it's hormonal replacement therapy or within dentistry, the different treatment options. So my main question is, are those treatments you mentioned currently funded, specifically for the UK, so through the NHS? Do you think they will continue to be funded? And then perhaps to you, Dr. Paula, within your long-term follow-up clinics, how are you managing talking about those treatment options which are currently funded? The reason I ask that is because I'm a survivor, and for many years, from the age of 12, I was taught about a particular treatment option, and it was kind of it was pushed for many years that that should be an option for me. And then when I became of an age that I would want to perhaps think about that option, I was told that it was no longer free on the NHS. So that's why I wanted to ask your question on those funding options. And for yourself, Dr. Paula, how are you managing talking to people about those funding options, especially if it's for further down the line? You know, we're not talking 1 year post-treatment, we're talking perhaps further on. Does that make sense?
Yeah.
Thank you.
Hormone replacement is funded, so that is not an issue. Fertility, assisted reproductive fertility, that's a different issue. So, for instance, egg cryopreservation in teenagers who already post-menarche after having periods, that funding are not there. There needs to be, you know, it's a proper fight, and it's a little bit of postcode lottery. So, and if you already had a baby through assisted reproductive technology, having a second baby is an issue. So from that point of view, yes, there is a problem with funding, but hormone replacement therapy, no.
And how do you talk about that in your clinic? Paula, have you come across that where you might be discussing those sort of treatments, and actually have you had a barrier where parents or the children or young people have asked you about those treatments, but you're not sure if they're funded? Things like, how have you found it in your clinic?
Such an excellent question. So I suppose about sensitive topics, I would always be asking permission of the young person if they want to be talking about that at that stage. If it's something that they have brought to the clinic, I think we're all a partnership, and I just think we're all working together to support them. And I'm always just honest, but with an understanding to discuss in an age-appropriate manner. Sometimes parents, they give me a call after clinic, or we organise a conversation because they want to have asked a few more probing questions, but just felt that actually the young person either didn't need to hear that, or maybe just wasn't in the right place to hear that. So I would say it's transparency, but in a supportive way, and always saying, well, actually, this is where we are now. We don't know what's going to change, you know, when you transition into adult long-term follow-up care. But these are at least the basics that you should expect. And we hope that either this is changing or this is what we're doing to try and change this going forward. So it's honesty, I think.
I think for us, like for me, I feel like fertility feels like that kind of big unknown, in that my son was 3 when he was diagnosed, and we were thrown into this whirlwind, and the last thing you're thinking about is this huge list of late effects that they give you. And so you just say yes. Of course you say yes, because your priority is the treatment that your child needs to cure them. But we're now sort of 7, 8 years down the line. I have no idea whether his fertility's been impacted. I don't know when we talk about that. I don't know how we talk about that. I don't know when that's going to be checked. I don't know how we even start to have that conversation with him. And so, yeah, it does sort of feel like that particular grey area that's just sort of hanging over our heads. I mean, I'm blessed. It was always sort of, if that's an issue we have in the future, then my God, we're in a lucky place, you know, and so you don't think about it. And that's still very much how I think, and we have lots of friends who've had children by all sorts of means, and so we know that, you know, there's lots of options out there, but it just feels like that one area that, I mean, everything's unknown, but it just feels like a particular area of, like, uncertainty that we don't quite know how and when we broach with medical professions or with our child.
Yeah, and I think it's a guidance to say, well, actually, we may not know more information until he is of a certain age, and at that age, we may do some more hormonal testing, but we are going to talk you through that. And if you think that actually he might want to wait another year or 2 after that testing for us to talk him through, it is all done on an individual basis. And we have these conversations weekly, and we get a really good feeling from the young person whether they're ready to talk about it. And if they're not, they know that they can come back and talk to us in the future about it.
Yeah, there we go.
I think one of the biggest things for me is that now I'm out of treatment for many years now, thank you. One of the biggest problems that I face is that I could go to loads of different clinics and not one of the doctors has, you know, communicated with other people. I find it really difficult to go into like a hematological appointment and be like, this is what's happened in 6 months, and then go, okay, right, why is no one doing a multidisciplinary thing for you? And I'm like, who do I ask for that? Because I see oncology once every 18 months. I'm flabbergasted I've actually got an appointment end of March. But I'm really struggling to find a sort of consistency where every team that I'm under knows about each other, because they're all just like, who are you under? What are you here for? You know, X, Y, and Z. And I'm thinking I've got tons of problems and I have no idea who to speak to about it. Like, especially endocrinology and gynecology. I was basically neglected for 10 years, and my gynecologist did not run any basic testing for years unless I advocated for myself. And I hated going there because it was just, for me, I went into those appointments and all she would talk about was, when I was about 13 years old, in the future, you're going to get pregnant, you're going to get this, that, and the other. And I'm just like, I'm here, I'm menopausal, I'm infertile, and I feel like this is not the conversation you should be having. And it was just, we didn't really get a straightforward prognosis until a couple of weeks ago. We saw someone, by the off chance of going into adult endocrinology, who said, oh, I'm not sure you should be seeing us because you've got so many different related conditions. And she was like, well, actually, why is no one actually looking at you as a whole person? And I agree, you know, your whole body is kind of sort of skimmed and looked at, but it's never looked at as a multidisciplinary team. So I just wondered if in the future, would there be any possible chance of having, I guess, like a team of people in, I don't know, oncology or late effects or something, where you've got gynecology, endocrinology, dental, physio, stuff like that in one room, so you don't have to spend months of, you know, emailing different people to get an appointment for, you know, next year.
Yeah, absolutely. I can answer that. It's a really important point that you broached, because it can feel like a full-time job, keeping up with correspondence and advocating for yourself. And there are different models all over the country with different funding avenues. But what we do for our young people in our clinics is that we try and do all the hard work before you come. So we have a copy of all the letters from the different hospitals. We spend hours reviewing all the notes before you come in. So when you walk through the door, I'll say, hey, how was it at the lung function testing the other day? I've got the results. How are you feeling about it? Rather than you having to update us on every single test that you've had in the last year.
And if I can comment as well, because I think where you started the journey, it was very different, whereas now we are beginning to understand much more and how much coordination it takes. So hopefully now more and more centers are realizing that, and therefore, like what you said, having a multidisciplinary and multi-speciality clinic put together is happening, or at least we hope is happening, in especially the young adults. But I'm afraid in the adult world, it's really different. And how we break that barrier and how we make them understand what is actually needed and how well or efficient it will work is what I think we're all trying to move towards.
Thank you.
Yeah. Thank you. We have Donna there, so online.
Yes, thank you. Yes, we have a mom who has a dental question about double teeth. She said her daughters had, for a long time, double teeth. Baby ones just wouldn't fall out with her adult teeth fully in. And then this happened with her front two teeth, and it took like 6 to 8 months for her baby teeth to fall out. Now it's happening again with one of her incisors, and she wants to know, is there anything she can do to encourage the tooth to fall out apart from using a string and a door?
All that means is that the growth of the next tooth is not happening in a position it should, because your baby tooth, when it comes out, should look like a little shell. The root should have been dissolved by the tooth coming up underneath. So it's really common. In fact, I had the same thing with my teeth. I had double teeth for years and years. And so you can't stick it onto a door, because when you pull it out, you've got a whole root that's stuck in. It's not being dissolved, so don't do the door thing. Even though it happened to me, don't do the door thing. But there's nothing you can do to encourage it. They need to be taken out at the right time. Yeah, thank you.
And I think we can take one last question.
Hi, I've got 2 questions for the dental ladies, please. My daughter Poppy, she finished treatment 2 years ago and she's 9 years old now. We were never really asked anything about dental treatment, only the same as Hannah before high dose. So we just continued seeing our family dentist. Since she finished treatment, we've had quite a lot of times where we've had to have the fluoride treatment. I think she's got problems with her enamel. And our dentist told us it was something she was probably born with. I didn't realise it could be an effective treatment. But we have to pay for it every time. We have a private dentist because we've struggled to find an NHS one in our area. And I'm wondering now if I should be trying to fight for specialist dental care, which isn't going to cost me money every time we go.
Sorry, how old did you say she was when she was diagnosed?
She was nearly 5.
Nearly
Now
5.
9.
So if it's on her front teeth, it possibly was something that it was at the time of birth. So when I said that kind of insult that happens at the time of birth where there's a trauma to the system, usually we see that hyperplasia, the weak teeth, on your front incisors and your first adult molars, because they are the ones that are growing at that particular moment in time. So any early childhood illnesses, they often present as hyperplasia. So it might be something that was at that time. But that still means if it's severe, you should be eligible to be seen by a specialist. If it just needs fluoride, then the difficulty is finding a local dentist that will see you. But I'm happy to have a chat afterwards to see where you live, to see if I can connect you with a specialist in your area, if that's useful.
Thank you. I also wanted to ask if you have any child-friendly resources, because we really struggle with trying to let her know how important it is. I know they get basic education at school, but I think for her it's even more important. And she really hates brushing her teeth, and it's a battle, and without scaring her, I want her to realise how important it is.
Yeah, so the British Society of Paediatric Dentistry has a lot of resources on their website which are really useful. What I find for my kids, if any of your kids like music, is there's an app called Brush DJ, and you can download it and it takes any song off your phone and it plays it for 2 minutes. It's got a little mouth and it lights up every kind of 30 seconds for each corner of the mouth, so you know you're supposed to move to a different corner at each moment. So it's basically making gamification of it. So there are fun things that you can do, but I mean, with my kids, I just show them pictures of rotten teeth. That's the truth of it. If you want that other chocolate, that's what's going to happen. But,
So basically scary pictures.
essentially, I'm not saying take a leaf out of my book,
that,
but
yeah.
that's what I do.
Okay, thank you.
Right. So I think on that note, if there are no burning questions, I would like to thank the panel. It's been really informative and it's been really helpful. Thank you very much.